So yeah, I will be focusing on multi-level tobacco cessation interventions and really exploring those through a health equity lens. So before I begin, in the spirit of reconciliation, I would just like to acknowledge that I live, work, and play on the traditional territories of the Blackfoot Confederacy, and that includes Siksika, Kainai Piikani, and then the Setsuna, Stoney Nakoda Nations, and Métis Region 3, and all of the people who make their homes in the Treaty 7 region of southern Alberta. So just a little bit of background about my placement. I worked with Alberta Cancer Prevention and Legacy Fund, and ACPLF has a goal to translate new knowledge into innovative, scalable cancer prevention and screening interventions to reduce modifiable cancer risk factors. And so during my time with ACPLF, I completed 2 projects, the first one being a scoping review and then a health equity impact assessment. And both projects focused on multi-level tobacco cessation interventions in the workplace. So a little bit of background about the issue. Tobacco is the leading modifiable risk factor for cancer, and it is actually linked to the highest proportion and number of cancer cases compared to all other modifiable risk factors. And we know that insights from tobacco control efforts have shown us that individual level tobacco interventions may be more effective when they're combined with interventions in other settings. So that can include incorporating interventions that address the workplace rather than just solely focusing on the individual. So considering that, the scoping review, our research question was, what multi-level tobacco control programs exist in a workplace setting? And we specifically looked at 3 main objectives. So which multi-level tobacco cessation programs are effective? And then for whom are these tobacco cessation programs effective? And then lastly, really looking at the barriers and facilitators to implementing a multi-level tobacco cessation program. So a multi-level approach was defined using the social ecological model as the theoretical framework. And we did this because it emphasizes the importance of interactions between environmental and social determinants on individual health behaviors. So for an intervention to be considered multi-level, it must target, intervene, or incorporate 2 or more of these levels. So an electronic search was done to identify all potential sources and studies, and the original search produced 143 sources, and 9 studies ended up being included for the overall qualitative synthesis. So now we'll really get into the results. First focusing on which multi-level tobacco cessation programs are effective in the workplace setting context. And our scoping review found that the most common levels of intervention were individual, interpersonal, and organizational, and only 2 studies incorporated 4 levels of intervention, and none incorporated all 5. And we saw that the most common interventions that were offered were individual counseling, group therapy, referrals to community programs, and then subsidized nicotine replacement therapies. So then we really looked at, so what populations are these tobacco cessation programs effective for? And this was grouped by age, gender, education, and income. And we saw that middle-aged men had higher rates of participation, while young adult men were particularly hard to engage. And then considering gender, we saw that employees who were women were more likely to extend their program to the spouses if given the opportunity, so really into that interpersonal level. And then we also saw that men had higher rates of participation compared to women. And then considering both both education and income, we saw that financial incentives were an effective strategy for individuals with low levels of education and income. And that was when it was combined with another intervention, such as group therapy. So then considering the relevant barriers and facilitators, we saw again that financial incentives were an effective facilitator for those with low levels of income and education, but we also saw that integration with occupational health and safety was a facilitator because when interventions integrated and collaborated with employers, employees were more likely to participate as they felt they had the support of their employer. We also saw social and peer support as a key facilitator. So the findings suggested that employees were more likely to participate if they had a positive peer relationship at work. And you could see that peer relationships really acted as a key motivator. And then lastly, we have accessibility, and accessibility can act as both a barrier and facilitator. So, for example, it's important to ensure that an intervention is held at work so that it makes it easy for employees to attend. However, not all interventions are accessible to all workers. For example, if we consider something like shift workers, are the interventions that are available for day shift workers also available for those on the night shift? And then we have mental health. The scoping review also revealed that depressive symptoms influence rates of abstinence and quit rates. And then lastly, we have costs. And this could be costs for the employer or for the individual, such as the cost of nicotine replacement therapies or just overall program costs. The results were really used to inform a health equity impact assessment, and I will just go over some of those key important findings that were revealed. So again, the key populations were identified, and those ended up being men, women, middle age, and young adults. And then we had industry in there, so both blue collar and white collar workers. And when we were identifying the relevant social determinants of health that are influenced or impacted by these multi-level interventions, we noticed that there was a pattern, that some of these social determinants of health touched on multiple populations. And these included gender, age, income, education, and then personal health practices and coping skills. And this really highlighted where the different populations were intersecting. So then we also looked at the potential impacts of these multi-level interventions. And so when compared to the results of the scoping review, there were several similarities surrounding the impacts of multi-level interventions on populations. However, the health equity did identify additional information, and specifically the HIA yielded more information on negative implications surrounding gender. It was revealed that it can be difficult to convince both men and women to attend these interventions at work. And then the HIA also revealed that a negative implication that arose for individuals with low income was that they were more likely to miss out on interventions as a result of shift work or access to resources. And those resources can include things such as computers, internet. And then we also see, when we consider age, we can see that a positive implication that was revealed for young men was that the intervention early on could lead to lifelong healthy behaviors as well as long-term cost savings for the employer. And that was as a result of less days absent and decreased insurance costs. However, we also saw that young adults were more likely to face social pressures and less likely to participate. And then lastly, for industry, we saw that intervention at the workplace improved accessibility for both blue collar and white collar workers. However, considering this, it can also increase existing health disparities. So important again to consider if an intervention can be held in both industries. An intervention that could regularly be held in a break room might not be able to be held at a site such as a construction site. We also saw social pressures and a loss of socialization during smoke breaks, and that was really in particular for those in the construction industry. So then, considering all those positive and negative implications that arise, it's important to identify mitigation strategies in order to amplify those positive impacts and really work to minimize those negative implications. And the health equity impact assessment revealed that there are really three key mitigation strategies for this. And the first one being targeting those peer relationships. So we know, or targeting that interpersonal level of the social ecological model, because we know that peer relationships have the ability to have both a positive and negative impact. And that's particularly important for young men. We also saw that company and leadership support was a very important mitigation strategy. Again, employees were more likely to participate if they had the support of their employer. And then lastly, ensuring that interventions are accessible. Really important to ensure that interventions are during paid work hours, so it makes it easy for individuals to attend. And that can also range to ensuring that individuals have access to resources. So, to conclude and to wrap up, the workplace provides a really unique opportunity to intervene on modifiable risk factors, such as tobacco use. An implementation of a multi level intervention that targets two levels of the social ecological model has the potential to disperse these positive impacts beyond just the individual. And then, lastly, when we're monitoring the impacts of these multi-level interventions, there's a real need to move beyond monitoring at the aggregate level and work to contextualize intersecting populations and the social determinants of health in the workplace. So really questioning, why do men have higher participation rates? Why do women have lower participation rates? And questioning, why are young men hard to reach? So then, all in all, I would just like to thank Dr. Nigel Livingston for support from the university, and then, of course, my practicum supervisor at Alberta Cancer Prevention Legacy Fund, Dr. Lisa Allen Scott. I feel incredibly lucky to have had this opportunity and this opportunity to grow.